Good morning. Last 2 days we had a very stormy session. So without any delay we want to start because many people have to catch their flight and leave. So we are coming to the free paper session 3. It is on kidney transplantation. First I request the chairperson, Dr. Anita and Dr. Ranjani Mathu to take the stage. Chairperson, you can take over. Each presenter will have 8 minutes for presentation, 2 minutes for discussion. If you exceed the time, naturally you will get negative marks. So be prompt and finish it on time. So definitely there will be negative mark if you exceed the time. To the chairperson.
Thanks to organizing committee for inviting us for this session. I welcome my co-chairperson, Dr. Anita, to chair this session. We have the first topic by Dr. Kiran Ravi. The topic is BK virus nephropathy in renal transplantation and the effect of intravenous immunoglobulin A prospective longitudinal single center study in South Asia. So over to Dr. Kiran Ravi.
Good morning, respected teachers, colleagues, and my dear friends. I'm Dr. Kiran. I'm first year DNB resident, Lakeshore Hospital, Kerala. So as we all know, BK virus nephropathy is an emerging cause of early graft dysfunction. Detection and management is challenging, and there is high chance of graft loss. Treatment options are also limited. The management and screening in Indian population is not well studied also. To our knowledge, this is the first South Asian follow-up study of BK virus nephropathy in transplant recipient treated with intravenous immunoglobulin. So my aim was to assess the prevalence and treatment of BK virus nephropathy in patients who underwent renal transplantation from 2018 to 2020 and a 1-year follow-up analysis, and to assess the efficacy of treatment with intravenous immunoglobulin who had biopsy-proven BK virus nephropathy. So there were 371 patients who underwent renal transplantation from 2018 to 2020. All were screened for BK virus viremia with quantitative serum PCR, DNA PCR every 3 months till 1 year after transplant. Those who had significant viremia underwent renal allograft biopsy. So our treatment strategy was, all patients who was found to have BK virus viremia, we have stopped the antimetabolite, and we have modified the tacrolimus dose to achieve a trough level of 4 to 6 nanogram per ml. And we added leflunomide. And all patients with biopsy-proven BK virus nephropathy, we have given intravenous immunoglobulin or a dose of 2 gram per kilogram over 5 days. So coming to the results, out of 371 patients, 14 patients was found to have BK virus viremia. And coming to the immunosuppression, we have given ATG out of 14 patients, we given ATG to 7 patients, basiliximab to 7 patients, and maintenance immunosuppression was standard. So coming to the distribution of age, mostly the patient fall in 40 to 60 years of age group. And coming to time of presentation of BK virus viremia, all patients present within 1 year after transplantation. So creatinine level, we take the mean baseline creatinine was 1.32. When we diagnose it, it was 2 milligram percentage. So when we take the ATG versus basiliximab group, we didn't find any significant differences between when we take the time of presentation, baseline creatinine, mean serum creatinine, and mean BKV PCR copies. There were no significant differences between these two groups. Coming to the diagnostic test, we found that there were 12 patients who found positive for urine decoy cells and 2 patients were negative for urine decoy cells. And when we done a renal biopsy, 12 patients found to have positive for BK virus nephropathy and 2 patients found to have negative for BK virus nephropathy. So based on the histopathology, there's one Banff criteria for polyomavirus nephropathy, which is classified into class 1, class 2, and class 3, which will see the polyomavirus load and chronicity index. Based on that, this BK virus nephropathy is classified into class 1, 2, and 3. So in my cohort, there were 4 patients in class 1, each in class 1, class 2, and class 3. So this is the histopathology pictures. We can see the urine decoy cells. You can see the large basophilic nucleus with clumped chromatin. And we have the histopathology. We have the intranuclear inclusion bodies in the tubular epithelial cells, and which should be confirmed with the IHC, that is SV40T antibody staining. So you can see that black dots. This is the IHC staining, which is confirmed. And we can see the chronicity index in this, which we have the interstitial fibrosis. This is how we classify the polyomavirus nephropathy. So in our cohort, when we take the median time of presentation in each class, in class 1, 12 months, class 2, 6.5 months, and class 3, 14 months. When we take the median serum creatinine, it is class 1, it is 1.4, class 2 is 2.1, class 3 is 2.2 milligram percentage. So we will take the follow-up after first year and second year. In class 1, we have 4 patients. So we can see the creatinine is almost the same as we have the creatinine diagnosis, 1.1, 1.3 like that. So class 1, the creatinine is almost same in the first year and second year compared to the creatinine diagnosis after treating with intravenous immunoglobulin. So in class 2, we can see that in first year and second year, the creatinine stabilizes at a more higher level. But all the graphs have survived after treating with IVIG. Coming to class 3, we can see that even after treating with IVIG, 2 patients has closed their graft and went into maintenance hemodialysis. Another 2 patients, the graft survived and the creatinine stabilized at a more higher level. So 2 patients we have BK viremia only without nephropathy. The creatinine is also stabilized almost same as in diagnosis. So after 1 year follow-up, we can see that out of 14 patients, after treating with our treatment strategy and IVIG, 12 graft has survived and 2 graft lost. It's almost 86%. So to conclude, BK virus nephropathy is a cause of early graft dysfunction, and in my cohort it was documented first 15 months after renal transplantation. And our study did not show any increased prevalence of BK virus nephropathy with patients with a higher immunosuppressive burden as with ATG, and we didn't have any extra immunosuppression also. And graft biopsy is so important as the histopathological has prognostic relevance and treatment outcome. In my study, we can see that the class 1 BK virus nephropathy have a better 1 year prognosis compared to class 2 and class 3. So multi-pronged treatment with upfront administration of intravenous immunoglobulin appears to have a reasonable salvage of graft function at 1 year, almost 86% in my study. So my limitation of my study is a low sample size. We don't have a control group, and we need more follow-up. Thank you.
Yeah, I have a question. So you have given immunoglobulin to all of them.
No, who have proven to have BK virus nephropathy.
Yeah, agree, for those. And the prognosis has depended upon the histology.
Yes.
Correct? And the immunoglobulin itself has not done a change if there was more severe a disease.
Yeah, that is what, class 3.
But you said you don't have a control wherein you have not treated with IVIG and you have a biopsy and how the prognosis was, correct?
Yes, yes, yes.
What is the utility of decoy cells in the study?
So decoy cells is a qualitative test, but sensitivity is not that, but it have to be confirmed the renal biopsy. By doing urine decoy cells, it only show the virus is replicating. It doesn't mean that the patient is BKV nephropathy. So it is just telling that you have a replication going on. That's it.
Okay. Your study was good, I think, because it was a prospective one, and it was a good for this thing. Follow-up was done. And also, I think I congratulate you for at least some patients who have been salvaged with immunoglobulin therapy.
Any other questions from the audience? Okay, if not, we'll move on to the next topic.
Thank you.